Hello, everyone. I would like to welcome you to the 11th Mayo Clinic annual Living with and Overcoming My Cancer Symposium on Central Nervous System section. During our time together, you will hear from our experts, Dr. Porter and Dr. Vora from Neurological Oncology and Radiation Oncology Department. I'll be your guide through this experience. My name is Dr. Maya Hrachova. I'm Neuro-Oncology Fellow, and I'm honored to be with you today. Please feel free to submit your questions in the chat box or under questions Q&A section. And let me introduce our first speaker, Dr. Porter. She is a Mayo Clinic Associate Professor of Neurology. She received her undergraduate degree in English with a minor in biochemistry from Spelman College, which was followed by a medical degree from Temple University. She had her neurology residency and neuro-oncology fellowship training at Mayo Clinic in Rochester. And she subsequently joined Mayo Clinic in Arizona, where she takes care of patients with central nervous system tumors for the last 12 years. Dr. Porter, please welcome.
Thank you so much, Maya, and welcome everyone. It's a pleasure to be with you all in this way. As Dr. Rachova mentioned, I'm a neuro-oncologist, which means that I've done neurology training followed by a neuro-oncology fellowship, which is what Dr. Rachova is doing now. And so my primary area of expertise is caring for patients who have tumors of the brain and spinal cord. And those tumors can be both malignant or they could be benign. So in addition to taking care of patients with primary brain cancers, I'm also kind of considered one of the neurologists for the cancer center. So we know that patients who have other malignancies, whether it be a solid organ tumor like breast cancer or lung cancer, or a hematologic malignancy like lymphoma, they can also have neurologic manifestations of their disease. And that can range from spread of their cancer to the nervous system, or possibly even neurologic side effects as a result of their cancer and or its treatment. And so I thought I would spend just a couple of minutes talking about, in general, the treatment approach as it pertains to glioma, which is a tumor that starts within the brain itself. And so the most common glioma is glioblastoma, and that's a tumor that tends to strike in middle age to later in life. It's more common in men than in women, and is highly aggressive. And so for patients with glioblastoma, their treatment really is multimodal, meaning that it requires various disciplines to come together to try to palliate or keep the disease under control for as long as possible. And so for most patients who are being treated for glioblastoma, the treatment includes a combination of both radiation and chemotherapy. The chemotherapy is a pill called Temozolomide that's taken daily throughout radiation. And then after that, there's a 1-month break. And then following, the patient will be on the Temozolomide, the oral chemotherapy, for at least 6 months. There's a medical device that is relatively new-ish. It became approved by the FDA in 2015, called Uptune. That's the short name. The longer name is Tumor Treating Fields. And it's a device that is applied to a freshly shaved head. And when plugged in, there are these tumor treating fields, electrical fields, that keep the tumor cells from growing and dividing. And so the idea behind its use is that in combination with chemotherapy, you really come at the tumor from 2 different directions to continue to keep those cancer cells from growing and dividing. And so that's the most common treatment that we're offering for patients with high-grade glioma or glioblastoma. Again, it's a combination of radiation plus chemotherapy followed by a 1-month break, and then a combination of either temozolomide, the oral chemotherapy on its own, or the chemotherapy with the tumor treating fields, or Optune. If patients have their glioblastoma grow despite that initial first phase of treatment, that then would be called recurrent glioblastoma. And there are just a couple of medications that are approved by the FDA for use in recurrent glioblastoma. One is called Avastin, which is the short name. The long name is bevacizumab. And that's an infusion that's given every 2 weeks in the vein. And there's another that's an older chemo pill that's called CCNU, or lomustine. And so those two medications, plus occasionally some older chemotherapies, might be tried within the recurrent setting. But we always take a step back, recognizing that there might be room for surgery, or there might be room for radiation, as Dr. Vora will tell us more about in just a moment. Or maybe there is an opportunity for implanting either chemotherapy wafers or radioactive wafers as another option. And so this has been our main approach for glioblastoma. I hope that within my career time, we'll start to see more treatments emerge, given just the limited number of medications that are possible for us to use. So I mentioned that I take care of patients who have primary brain tumors, but also that I'm kind of the neurologist for the cancer center, if you will. And so one of the most common things that I end up seeing patients for complaints in regards of their thinking and memory related to their cancer treatment. And sometimes the issues of cognition come up after having had radiation. Sometimes people experience changes in their thinking and memory related to chemotherapy. You may have heard of something called chemo brain. That's kind of an indistinct, not quite specific decline or difficulty with the thinking and memory that often is steeped in forgetfulness or just some cognitive impairment. But it can really range. And for some patients, their symptoms progress to being much more severe and almost mimicking a dementia sort of picture. And so that's one of the things that patients may see me with complaints of in terms of their thinking and memory. One of the other things that I end up seeing pretty regularly in our practice is neuropathy. So that is numbness and tingling in the hands and the feet typically. That could be related to chemotherapy. And so there historically are some chemotherapies that are well known to cause neuropathy. And the main treatment for that is, once we identify that that's what's happening, is trying to reduce the dose of chemotherapy so that it's not as toxic for the nerves. And if the neuropathy continues to get even worse, sometimes we talk about holding or switching the chemotherapy altogether. For some patients, we find that once we've held the chemotherapy, it can take up to a year before the symptoms start to improve themselves. For other patients, they're left with a sense of numbness or tingling or burning, and we do our best to try to use different medications for what we call neuropathic pain to try to alleviate the symptoms as much as we can. Unfortunately, we don't have very much in the way, we don't have any real effective way to regenerate damaged nerve cells or neurons. And so for that reason, we're left with trying to treat the symptoms as best as we can. So I think with that, I'll turn it over to my colleague, Dr. Vora, who maybe Dr. Rachova, I'll let you properly introduce Dr. Vora. Thank you.
It's my pleasure to introduce Dr. Vora, who is Associate Professor of Radiation Oncology. Dr. Vora received undergraduate degree in biochemical engineering from the Johns Hopkins University, followed by a medical degree from University of Pittsburgh, and he had his residency training in radiation oncology at Tufts New England Medical Center. Dr. Vora has been caring for patients with central nervous system tumors for more than 20 years. So he has vast experience, and we're very happy to have him here. Dr. Vora, please.
Well, thank you so much for that introduction, and thank you everyone attending for taking some time out of your day to spend with us. I'm originally from upstate New York, and I've been out in Arizona for about 20 years, looking for a little bit warmer weather compared to the cold of the Northeast. And I've really grown to love where I work and who I work with. But ultimately, it comes down to what we do and what we try to do for our patients. When it comes to brain tumors, we're humbled pretty much every day in terms of how we take care of patients, what we can do for them. But I am excited in that there have been quite a bit of advancements in trying to do much better for our patients, not only in terms of allowing them to live longer, but also living with good quality of life, because I think that's just as important. Aside from primary brain tumors, I do have interest in cancers that have spread to other parts, from other parts of the body to the brain. So the term for that is called metastatic disease. And it's something that's seen in about somewhere between 250 to 350,000 patients per year. So this is something that almost all cancer patients that are diagnosed with cancer can potentially have. Some cancers are more predisposed. For example, lung cancer, we tend to see a little bit of a higher rate of cancer spread to the brain, while other cancers like prostate cancer, we tend not to see it very often. That being said, I think we're seeing it at a higher rate compared to years past, primarily because as a specialty, oncologists are doing a better job with the advancements in science and allowing patients to live longer. And secondly, the increased use of medical imaging, for example, an MRI, has allowed us to detect metastatic lesions at a much earlier rate, many times before the patients even notice it. So once we, if we're in the situation where we have detected a cancer in the brain, our ability to treat this is much, much better than years past. It really carried a much more ominous prognosis 10 years ago, 15 years ago. But now there have been quite a bit of advancements, particularly in the molecular side of understanding the genetics of how cancers behave, and finding more innovative ways of trying to treat these cancers. So, the main tools that we use right now are surgery. We sometimes use radiation, and we sometimes use special drugs that have the ability to treat problems in the brain as well. So it's the multidisciplinary team between Dr. Porter, myself, and our neurosurgeons, where we really try to come up with the best way of helping and coming up with the best plan. We meet every week and we will discuss cases. So we have these things called tumor boards where we'll have radiologists and pathologists and all the doctors of different disciplines within oncology to meet as a group. And what we really try to do is try to come up with what we think is the best way that might come to trying to approach this particular patient with this particular type of treatment. Obviously, it's a two-way street, so it's really important for us as physicians to listen to your concerns and make sure that we address them because there's clearly not a one-size-fits-all. It really does require the doctor-patient relationship as well as the doctor-team relationship to try to come up with an ideal way of helping. As you heard, I'm a radiation oncologist, so my area of specialty within oncology is using radiation treatments. Radiation is basically a high-energy X-ray that we point more or less like a laser, and we use it to treat metastatic cancers that have gotten into the brain. There's a lot of different ways of doing it. There's one called whole brain radiation therapy, where we treat everything, not only what we can see, but also if there's microscopic cancer cells elsewhere in the brain, we try to address those areas as well. Those treatments have been optimized with the use of some medications and our ability to sculpt radiation away from sensitive parts of the brain to help with quality of life issues. Another modality that has gained a lot of interest and primarily what we use today for metastatic disease is something called stereotactic radiosurgery. So if you type that into Dr. Google, you'll see words like Gamma Knife and CyberKnife and Novalis, and these are all different brand names or platforms that allow us to deliver radiation with sub-millimeter precision. We use this quite a bit for our patients because it allows us to treat these individual spots while sparing the healthy brain tissue to even a greater extent, again, with the goal of preserving quality of life and primarily cognition in terms of thinking and memory. There are times where we have to combine radiation with surgery. There are times where we have to combine radiation with drug therapy as well. So that's why, again, I And as we get into some of these questions, I do want to kind of harp on the fact that it does require all of us to kind of work together to give you, really the best recommendations. So with that, I'll stop for a moment and we'll see if there's any questions that have come through.
Thank you, Dr. Vora. We'll have first question that I will direct to Dr. Porter. It comes from Mr. George Chen. He's asking, how do you differ from neuropathy and regular burning pain on chest or stomach after first 3 cycles of chemotherapy? And how do you treat the patients with numbness on their tongue during chemotherapy? And what usually is the medications that used for these treatments?
Yeah. Thank you for that. It can be a really complicated thing to try to figure out in terms of a chemotherapy-induced neuropathy. Typically, what patients will complain of is a sense of burning, or even I have patients tell me that they feel like their feet feel thick or like they're walking on cotton balls. Sometimes people will describe kind of an itch that starts in their feet and then slowly makes its way up to their ankles and then maybe to their shins. So typically when we're thinking about chemotherapy-induced peripheral neuropathy, it usually starts in the toes. And then once it hits about mid-shin or so, patients might start having symptoms in their fingertips also. There are so there's a couple of ways to be able to make the diagnosis. One is clinically. And so oftentimes if I'm seeing a patient who has concern for neuropathy, we'll go through a full neurologic exam, and that includes me testing muscle strength, reflexes, coordination, and then one of the most important features of the exam for diagnosing neuropathy is looking at sensation. And so we test the ability to feel and perceive pain, pressure, temperature, vibration, and knowing where the joint is in space. That's called joint position, to try to see what kind of pattern of sensory abnormality we may find. There are some chemotherapies that are known to just cause difficulty with sensation, so the ability to feel the sharp point of a pinprick, where there are other chemotherapies that are more well known to cause difficulty with knowing where the joint is in space. And so those sorts of symptoms can manifest themselves differently. Historically, some of the chemotherapies that we see most commonly causing a peripheral neuropathy are the ones that end in platin. So cisplatin, carboplatin, oxaliplatin, those are pretty well known to cause neuropathy. There are others like vincristine that can also cause neuropathy. Sometimes with chemotherapy-induced neuropathies, we see changes in the sensation or in the sensory or the motor nerves. Sometimes there can be symptoms of the autonomic nervous system where blood pressure might drop or not respond appropriately when you're upright or laying down. Sometimes there can be dry mouth, dry eyes, and those sorts of things. So when we talk about symptoms like numbness in the tongue, that can be a little bit more tricky. And so it's always important, if you're noticing something like that, to let the oncologist know, because we also know that there are different sores and things that can occur as a result of chemotherapy, which also might be having an impact. When it comes to symptoms in the torso, it's not common that neuropathy will show up in the torso first and not be present in the fingers and toes. And so we always want to make sure that there's nothing else. Sometimes if patients have had metastases or cancer deposits in the rib, sometimes that can impact nerve sensation in the area of the torso. Sometimes if a patient has had cancer surgery, for whatever reason, sometimes because those cutaneous nerves or those skin nerves were cut, that can cause sensory disturbance in the torso. So it's not quite straightforward in terms of whether or not neuropathy can truly be present in the abdomen in the absence of some of those other things. But as you asked in the question, gabapentin is one of those neuropathic pain medications that we use to try to dampen some of those aggravating symptoms. We don't have anything that can bring feeling back. So if the complaint is more of a Novocaine-like numbness, medications like gabapentin won't be as helpful. But if there's burning or itching or electrical sorts of pain, that's where medicines like gabapentin may provide some benefit.
Thank you so much, Dr. Porter. I will have next question for Dr. Vora from questions that patients ask us. Why is the duration of radiation therapy is this long, 6 weeks? And what are the common complications? What patients should expect at the end of radiation treatment?
Sure. Well, that's a good question. So I guess the first thing I should mention is that it depends a little bit on the type of cancer that we're actually treating. So for a glioma that Dr. Porter mentioned, the treatment length is generally about 6 weeks in length. And where does 6 weeks come from? It's a good question. What we're really trying to balance is the trying to reduce side effects while still trying to control the cancer. And we've learned from a lot of earlier studies of how much radiation it takes to be able to do that. And by doing the radiation over that period of time, it allows patients to recover faster, have fewer long-term side effects, and allow us to still control the tumor. So that's sort of how we address gliomas. For metastatic cancers, however, those treatment courses can be much shorter. So many of these, when we use that radiosurgery, stereotactic radiosurgery, those treatments can be as short as just 1 day. So that obviously is appealing in terms of convenience, but also quite effective. So many times when we're treating treating metastatic lesions, we're targeting much smaller spots, so we can kind of get away with giving a higher dose that can actually be done in a very short period of time. As far as the second half of your questions in terms of what are the anticipated side effects, it depends a little bit on the amount of brain tissue that sees radiation, as well as the location of what we're treating. So for some parts of the brain, they're considered what's called eloquent, where your speech comes from, where your strength comes from. And when radiation is given to those areas, there are some risks of causing some effects on either memory or strength or generalized weakness. Those things can occur from radiation. I always promote patients in staying active physically. It seems to make a big difference. I also definitely encourage patients to maintain good nutrition throughout radiation as well. Those are things that are within the control of the patient that really seems to help quite a bit in terms of minimizing the side effects.
Thank you so much, Dr. Vora. I will ask next question to Dr. Porter, also a very common question. What are the common side effects of temozolomide? What patients usually experience?
Thank you. So temozolomide is an oral chemotherapy. And during the radiation phase for patients that are being treated for glioblastoma or high-grade glioma, they're going to take the temozolomide every day throughout the radiation treatment. And so typically, the way that I prescribe it is I recommend that people take it at night before they go to bed, because the most common side effect associated with temozolomide is that it can be nauseating. And so I always give a prescription for an anti-nausea medication to take 30 minutes before the Temodar and then going to bed after that. That way, if there is some low-grade nausea, patients will typically sleep right through it. With the anti-nausea medication, and with the combination of the anti-nausea medication as well as the oral chemotherapy, sometimes patients have complaints of feeling constipated just because everything sort of slows down in the gut. And because this is an oral chemo, we want things to move through the system regularly. And so oftentimes we end up prescribing either stool softener or some sort of laxative in order to help combat the constipation. So nausea is the first side effect, followed by constipation. About 1 in 10 patients will have a significant drop in their blood counts. So we check their blood work at the beginning before we get started at about the midpoint, so week 3, and then at the end at week 6. about 10% will end up needing either a dose reduction in their chemotherapy or some other support, meaning we might have to give them some platelets or blood products in order to help keep their counts up, but that's pretty rare. And then another rare side effect that sometimes comes up with patients here in Arizona because of our hot temperatures during the summer months is sometimes people will experience an acne-looking rash over their torso. It doesn't mean that they're allergic to temozolomide at all. It's just unfortunately a side effect, and we provide creams and all to sort of combat that rash. But for the most part, Temodar is very well tolerated. Sometimes people ask me if they're actually getting something because they're not noticing anything, which on the way that I see it, that's a really good thing. I guess the last thing that I'll mention, so during that 6 weeks, when patients are receiving the combination of radiation with Temodar, people also often share with us that they start to feel fatigue or tiredness. And that symptom can be a lot more difficult because we know that radiation in some ways can cause a fatigue or a tired feeling, but also temozolomide can cause a bit of tiredness. And so we start to see more of that, not necessarily during the radiation phase, but during what we call the adjuvant phase, which is the 6 months of chemotherapy on its own after the radiation has been completed. And that's something that we try to navigate by lowering the dose if we need to, just so that people aren't feeling so wiped out, but that we know it's still being effective.
Thank you so much, Dr. Porter. I will ask Dr. Vora the next question, which also commonly comes up in our clinic. You did mention about proton versus photon therapy. Could you elaborate on the topic more and cite advantages of one versus the other?
Sure. So proton beam therapy is a different type of radiation that many feel is sort of the next generation of the way radiation will be delivered in the future. It's an area of a lot of interest, both in terms of research as well as in terms of clinical application and helping our cancer patients. The difference between protons and photons, sort of the easiest way to kind of explain it is photons are standard x-rays that kind of go through and through the body. So if anyone has ever had a chest x-ray or they've had dental work, the x-rays that are used basically are going straight through you. With proton beam therapy, the difference is that the radiation beam actually will stop after a certain distance. So it's kind of like a smart bomb. We dial up the energy, it goes a certain distance, it drops its radiation where we place it, and then there's very little radiation after that, which has some clear potential advantages when it comes to brain tumors, because one of the things that we're really striving for is trying to minimize the collateral damage caused by the potential for radiation or standard radiation. So what we do now is we'll design radiation treatments using proton beam, and we'll actually compare it to standard radiation to see the difference in the magnitude of benefit. For some areas in the brain, we can really see some large differences between the two, and many times when it comes to getting insurance approval, which is unfortunately part of reality, we can really show the insurance company that yes, we're clearly benefiting the patient by using this technology. For other cases, it's actually not as advantageous. So again, I think it's pretty important to talk to your doctor and your medical team to see if they feel that proton beam may provide some advantages. In the Southwest, we're really the only proton center. I think the closest ones to us are out in San Diego and going east towards Houston. So we do get a number of patients who come in from the adjacent states really interested in this technology. And while we do try to educate our patients, kind of explain to them that it's not clear whether protons will be better or not, there is that interest there for obvious reasons. We go to great lengths trying to see if there are advantages, and if there are, we really will fight for our patients and the insurance companies in getting these treatments approved.
Thank you so much, Dr. Porter. Dr. Porter, I'm going to ask you a follow-up question from Mr. Chen. He's asking if alternative therapies such as acupuncture can be used for treatment of side effects of chemotherapy, such as neuropathy or even other side effects.
Yeah, I'm so glad that, Mr. Chen, that you brought that up, because yes, there are some Eastern treatments that certainly have provided patients benefit for symptomatic relief. And we know that all of these medications that we're talking about, the neuropathic pain medications, in order to be effective, oftentimes they have to be taken multiple times per day. And because of that, the side effect can be that they're very sedating. And so if there are opportunities to use Eastern medicine, things like acupuncture, as you mentioned, then yes, that's something that wholeheartedly I would encourage for our patients, not just for neuropathy, but any cancer-related pain. Dr. Vora mentioned another thing that we know can really make a difference for patients and sort of how well they feel, and that's exercise. And I realize that it can be really tough if your feet are burning to go for a walk. But we know that if you're able to get some sort of movement in, whether it be in the pool or on a stationary bike, something like that, having that opportunity to raise the heart rate and really get your muscles and nerves working can also provide some symptomatic relief and help the nervous system function more optimally. But absolutely, therapies like acupuncture can be very helpful. I also have had a couple of patients that have found benefit with things like essential oils. There's one patient who told me that frankincense was quite helpful for them. I have other patients who have told me some home remedies, even using things like Vicks and then putting socks on for their burning feet, gave them some relief. And so I think it really is an opportunity that's ripe to be creative because we know that our treatments just aren't as good as we'd like. And there have been a lot of studies looking into how to prevent this side effect from occurring, whether we give patients vitamin infusions at the same time that they're receiving their chemotherapy, or other vitamins, things like alpha lipoic acid that are thought to be neuroprotective while patients are receiving their chemotherapy to try to stave off the symptom of chemotherapy-related neuropathy. And there really hasn't been much progress made in that area in particular. So yes, anything that may help, that won't get in the way of the cancer treatment itself is definitely recommended.
Thank you so much, Dr. Porter. Dr. Vora, I am aware that the Mayo Clinic Radiation Oncology Department has multiple clinical trials for glioblastoma patients. Can you educate me and our audience about them?
Sure, great question. Well, as I suspect many of that are part of this knows, we don't do as well as we'd like when it comes to glioblastoma. We're humbled and we're looking for more and more innovative ways of trying to treat patients with this diagnosis. There is not only at Mayo Clinic, but all around the country, this is an area of intense research, and we have sort of a multidisciplinary team that looks at different newer ways of trying to attack this problem. Currently, we do have trials, and again, when it comes to a clinical trial, I actually should explain this a little bit. A clinical trial is really looking at a potential newer way of trying to treat the cancer. It's not clearly a better way, but it is looking at something that's evidence-based that might provide not only better quality of life, but better survival as well. So that's what we're really shooting for. For glioblastoma, the trials vary in terms of studies looking at different types of chemotherapies. There are also different types of radiation that's also being looked at for this diagnosis. Within the radiation route, we're looking at utilizing proton beam therapy, for example, and trying to see if we can get radiation done at a faster rate while still trying to spare healthy tissues. We're also trying to incorporate newer medical imaging to see if we can see the cancers better so we can target them and treat them better as well. I think it's important for those that are interested in clinical trials to come to a tertiary care center like Mayo Clinic or other academic centers where they'll likely have a number of clinical trials that may be available. And that way the doctors can really study the details of your particular case and really see if there are potential for using an innovative clinical trial to treat your cancer.
Thank you so much, Dr. Vora. So I'm going to ask Dr. Porter about the potential clinical trials that can be possible for patients with GBM. And I know we have a viral therapy studies.
Yeah, thank you. There's been a lot of questions from patients about viral therapy and what that actually means. And so there are different institutions across the country that are using different viruses in order to stimulate our own immune response. And so there's a dendritic cell virus, dendritic cell therapy that's being offered at Mayo Clinic in Rochester. And ultimately what happens with that particular study is after the tumor is taken out, and this is for glioblastoma, and this is for recurrent glioblastoma. So if the tumor has grown despite the aggressive therapy that we've described previously, the tumor is grown, and then the patient is the tumor is resected, and then the patient is injected with virus in order to stimulate an immune response in the area where the tumor was. And so the idea is just we recognize that this is a tumor that we're going to have to treat coming from different directions. And so we've not been as successful as other solid tumors in using immunotherapy. So our colleagues who treat melanoma and treat lung cancer and breast cancer have really enjoyed some of the benefits of those medications. We haven't seen as much of a breakthrough when it comes to glioblastoma, but there might be some hope within this viral therapy that then stimulates the body's own immune response.
Thank you so much, Dr. Porter. And I just have one more question. We do get a lot of questions about Uptune. You did mention about it a little bit. Could you describe it in more detail?
Yeah, so Uptune is, and I actually have an example here in my office. It's actually a medical device that originally was tested in patients who have recurrent glioblastoma. And if this is the head, as I mentioned, it has to be applied to a freshly shaven head, and there are these arrays. And so there are ceramic discs that are attached to a sticky tape that's kind of like a Band-Aid material. And there are 4 arrays. So you have one in the front, one in the back, one on the side, and one on the other side. And then there are these cords that then plug into the device that then elicits these electrical or tumor treating fields. And so the data showed us that when this was used in recurrent glioblastoma, in comparison to physician's choice chemotherapy, this was just as good and did not hurt. And so once that step was proven, it was able to be tried in newly diagnosed glioblastoma. So that means glioblastoma that hadn't been treated before. And the trial that they did in order to seek approval was using it after the radiation phase was over and just the chemotherapy phase was going on. And so in order for it to be effective, it has to be worn at least on average 18 hours a day. And that time includes while you're sleeping. And so the wires can plug into a bedside table, or they can go into a battery pack that you wear as a backpack or as a crossbody bag so that you can continue to be as active as you'd like during the day. And so we found, or the data would suggest, that when patients use this in combination with chemotherapy, there's an improvement in overall survival as well as progression-free survival. One of the downsides of the Uptune is that it's very labor intensive. And so based on how quickly the hair grows back, patients may frequently have to then shave their head and reapply. For some people, is very cosmetic in that they don't like feeling as though they're wearing their disease or that they're frequently reminded about their disease. Because it's a bit unusual, it does garner some additional attention, and people might give looks and stares, and so that's something that has been off-putting about the therapy. And then the battery is larger than an iPad and has a little bit of weight to it. So it can be challenging for patients to get around if already you're dealing with weakness on one side of the body or have sensory changes. And so those are some of the things that keep patients from being as excited about Uptune therapy. But for those who are interested and have support caregivers who are willing to, help them with the head shaving and the reapplication, for patients who are very motivated, I find that it's a nice way where patients can also partner with us in the treatment of their disease. And it's something that they can do with very little risk to them. The biggest side effect associated with Uptune is that sometimes it can cause skin irritation or skin breakdown because of those little ceramic discs. And so that's why it's important that the arrays be shifted just very slightly each time they're reapplied so that it reduces the risk of irritation. But other than that, it's very well tolerated. It's not the kind of treatment that's going to make you sick. And so for that reason, I have found that patients have enjoyed that option for treatment.
Thank you, Dr. Porter, and thank you, Dr. Vora, for very excellent points and presentations. I would like to ask you if you have any final comments, and if our attendees have any more questions, please feel free to put them in chat or Q&A. Otherwise, we pretty much appreciate that you've been here, and we have a survey that you can complete. It consists of only 5 questions, and you can actually be entered to win a Mayo Clinic cookbook, which is a great resource. Dr. Porter, any final comments?
Yeah, I want to thank everyone for being here today. A few years ago, a colleague of mine and we wrote a book for patients and their families. It's called Navigating Life with a Brain Tumor. And the reason why we wrote this book is because we recognize that when you have this diagnosis, there's so many emotions that come up as a result. And often there can be questions that come up that are left unasked. On the patient caregiver side and also on the physician side. And so we really wanted to provide a resource for patients and their families to be able to have their questions answered from a reputable source, because we recognize the natural tendency is to turn to Dr. Google and to try to educate ourselves the best we can in that way. And so we really wanted this book to be a guide. And so that's why it's called Navigating Life with the Brain Tumor. And so it is available on Amazon. And if you take a look, we track the journey from the moment of diagnosis to the patient's last breath and beyond, including everything in between, and the areas that as physicians we're not as good at. So there's a whole section on planning for your future, understanding what a power of attorney is, a healthcare advance directive, all of that. We had some attorneys help us out. We had, for getting more details about radiation and what to expect and all of that, we had some radiation oncologists help us out. But many patients ask, how do I live with this? And so we have a big section of the book that is where we talk about things like diet and exercise and eating well, all things that have been touched on here today. And caregiver stress and burnout and fatigue, because we recognize this is a disease that really impacts the whole family. And so it's so wonderful that we have symposia like this where we can directly talk to patients and get those questions answered. But we also have that resource. And truly that piece of work has been one of the things that I'm most proud of in my career thus far. So I hope that for anybody who has additional questions, I hope that you found today's session helpful, because we recognize how difficult this road can be. So thank you, and I'll turn it to Dr. Vora for any final thoughts.
Well, I'd like to also thank all the attendees of taking time out of your day to spend with us. I hope some of this information was very helpful. If you have individual questions, please feel free to reach out to us. We'd be happy to help and answer any additional questions. But I just want to let you know that brain tumors, Dr. Porter and I, we care very deeply about them, and we know the impact it has on not only the patient but the families as well. And we realize that it really takes a village to really help, and we want to be part of that. And if there are questions that you still have that you may not want to ask in this forum, I think either of us would be very happy to address them afterwards.
Thank you so much, Dr. Vora, and one more time, Dr. Porter, and our attendees. And with that, we'll conclude our symposium. We very much appreciate your time. Bye-bye.